Welcome to the Cervical Cancer Survivor Series. I'm Martha Kempner with the American Sexual Health Association and the National Cervical Cancer Coalition. We recently reached out to survivors across the country to hear their stories of diagnosis, treatment, and survivorship, and get their advice for others whose lives are impacted by this preventable disease. We also talked to providers in the field to answer questions about screening, prevention, and treatment. In this episode, we speak to gynecological oncologist Brad Monk. Dr. Monk leads clinical trials and has authored or co-authored over 300 peer-reviewed publications on cervical cancer, ovarian cancer, and other gynecologic cancers. He also sees patients. We talked to Dr. Monk about finding a cancer expert and possible treatment options. Just to start, can you introduce yourself and tell us what your specialty is and what your connection to cervical cancer is?
My name is Brad Monk. I'm a gynecologic oncologist. I have in my background, if you're only audio, you can't see it, but the background says GOG Foundation, which is a nonprofit organization, which I'm the vice president of, and then GOG Partners, which is under the foundation, which I'm the director of.
And what does GOG stand for?
So it doesn't stand for anything, but it used to stand for Gynecologic Oncology Group. We wanted to preserve the acronym, and again, it's a nonprofit, GOG Partners, under GOG Foundation to do clinical research, such as cervical cancer. So I'm the director and founder of that. And so that's sort of my hobby, my part-time job. I'm here in Florida in West Palm Beach, Florida Cancer Specialists and Research Institute. We care for about 2/3 of all cancer patients in Florida, if you can imagine. And I am the medical director of phase 2 and phase 3 oncology trials across 30 cancer centers here in Florida. My relationship to cervical cancer was as a medical student. I met a Latina woman while I was going to medical school in Arizona with cervical cancer. And initially, surgery was how these patients were treated. And the surgeon says, if we can do this skillfully, we can save this woman's life. I'm like, oh, that was interesting. And we did it, and she was cured. And but there were two things that were interesting about that encounter. Number one is that she got cervical cancer because Pap testing has been around for 50 years, and that I was told that chemotherapy doesn't work. And thirdly, that this was a disease of marginalized and a diverse population, which at the time was not even part of the conversation. And so I've been a passionate advocate for diversity and various types of inclusivity and equity, and a cervical cancer advocate and caregiver, provider, clinical trialist. This is a life's work, and I'm very passionate about, number one, preventing it, but when it occurs, defeating it.
Well, actually, that's great because we're going to talk about both of those things today. So thank you so much. I want to ask you just how widespread cervical cancer is in the United States and whether that's changed over the course of your career now that we have the HPV vaccine.
It affects about 14,000 Americans. It kills about 4,300. Surprisingly, those numbers have remained unchanged since the Pap test came on. We reduced the number of cases dramatically, and then it plateaued. And the Gardasil, as I'm going to call it by its trade name, which was initially against 4 types, 6, 11, 16, and 18, now has been, and just in girls, has now been expanded to adults and men, and has 5 additional HPV types added, Gardasil 9. A lot of this is related to miseducation and also our healthcare system that doesn't support preventative care, unfortunately.
HPV is also linked with warts. The HPV that causes the wart on my toe that I had last year, is that the same as the HPV that causes cervical cancer, or is it different?
So there are more than 100 types, and so what we try to do is overcome the most common types. The 2 most common wart-causing types are 6 and 11. Virtually all warts are caused by those, including the one on your digit, and also the wart on a person's external genitalia. The cancer-causing types are, the most common is 16, and cervical cancer is so prone to HPV carcinogenesis that there are other types besides 16, such as 18 and others, and that's where the additional Gardasil types came from. But 16 is most of anal, vulvar, vaginal, and head and neck cancers. In cervical cancer, it's 16, 18, 31, and so on, 33, 35.
And how do we know? How does someone know if they have those types?
I know all of you remember COVID. I know we've tried to forget. And how do you know if you have COVID? You get a viral test. And how do you know if you have the virus? You get an HPV test. It literally is that simple. And the opposite is true. Now, you may not, believe in vaccination, and you're hearing the RFK Jr. and all of that sort of misinformation. But vaccination saves lives. So Gardasil is safe. And if you want it, and if we learned from COVID, if you want to know if you have it, get tested. And if you don't want to die from it, get vaccinated.
Let's go back to talking about screening for a second. You say that you get HPV tested the way we all stuck Q-tips up our nose for COVID, obviously not our noses. But the question I have, or that many people might have, is this the same as a pap smear, or is this different than a pap test? I know we don't call them smears
Yeah.
anymore.
So the collection process is the same as a pap. Generally, it's a brush. So if you were to look at the cervix as a canal, you can enter it and brush it rather than just the ectocervix. You should do both. A brush is very important than just a spatula like a tongue blade. And it's deposited the cells in a liquid. And in that liquid, you can centrifuge it down and look at the cells under the microscope, the pap test as you described. But the more sensitive test from that liquid is to look for the virus. And that's an FDA approved, American Cancer Society preferred method for cervical cancer screening.
So, how does someone get diagnosed with cervical cancer? I know you can get a positive HPV test, but when we're talking about cervical cancer itself, how does someone find out that they have that?
So medicine is about taking a history and doing a physical exam, developing a differential diagnosis, and ordering appropriate tests. So you take a history. Hey, are you having any bleeding? Postcoital bleeding? Have you had a pap test before? When was your last HPV test? And she says, yeah, I've had HPV testing my whole life and they've all been negative. The chance that that woman has cervical cancer is low. And then you examine. And you examine the patient. You do a speculum exam, looking at the cervix. Okay, you also can do an internal exam. A pelvic exam is both a vaginal and a bimanual rectal examination. And then you screen appropriately. And the diagnostic test obviously would be the screening, the pap test, and the HPV test. And if you see something, you should biopsy it. And the biopsy can be done as an outpatient. We've tried to give anesthetic for it. It's just injecting the cervix with a needle is about as traumatic and painful as just doing the biopsies. The biopsies are very small, about a quarter of an eraser tip. So number one, high level of suspicion. Number two, history, physical examination, appropriate testing, and quite frankly, seeing someone that's skilled. Now, because cervical cancer is so rare, it's not uncommon to go to a provider that's never seen a cervical cancer. Think of that.
So, we talked to a lot of women in the last few weeks who have survived cervical cancer. And most of them talk about having, either gone to a provider who did a visual exam and said something didn't look right here, or getting an abnormal pap. A lot of them told us that one of the first things they learned about their cancer was what stage it was. How do you figure that out, and what does it mean?
Listen, if something doesn't seem right on the cervix, right there, right then, you should do a biopsy.
Okay.
So stage is just a fancy word for extent, and stage doesn't change. So the stage is a newly diagnosed extent, and it's based on the size of the tumor. It's based on local extent, because it can go into the vagina and the paracervical soft tissue, even block the kidney or go into the bladder or the rectum right there. Or it can metastasize to the lymph nodes, or it can metastasize in the blood. A cell breaks off and goes to the liver or the lung, or it can even break off and spread in the peritoneal cavity. So you get the sense, right? So a little cancer on the cervix is a stage 1, a bigger cancer in the paracervical soft tissue is stage 2, in the lymph nodes it's stage 3, and if it's metastasized it's stage 4. So it's pretty straightforward, and it's just a lexicon, it's a language to communicate the extent. Now, staging is based on physical examination and imaging. The best imaging in the pelvis is an MRI with contrast in the vagina. MRI is is the soft tissue imaging of choice. And then ultimately you can do a PET scan to see if it's spreading outside of the pelvis, generally an MRI of the pelvis, a PET scan of the whole body, and a physical exam.
Let me ask you this. From a patient's point of view, they've gone to their regular gynecologist, let's say, and they've gotten some of these tests done, and they now know that they have cervical cancer. What should they do next? How do they find a gynecological oncologist? And who else might be on their care team?
Yeah, there are a lot of good training centers that are less known, but generally, if they trained at a board certified training facility and are board certified, you can be assured that they're trained. And you can ask so you ask the OB/GYN doc, why are you sending me to this Dr. Smith? They may say, well, Smith is the only, provider that your health insurance pays for. I'm not sure what to do then. But if they say, well, I'm sending you to Dr. Smith, Dr. Smith is a world's expert in cervical cancer. And I really like his style, and he has a comprehensive team, and he actually cares. He's in this for you. I want that doctor.
Who else might they have, on a care team? It would be your doctor. I know we had some women who talked about seeing specifically a radiation oncologist or specifically a surgical oncologist. Does that often happen?
Well, gynecologic oncologists should be the surgeon. They should essentially never see a surgical oncologist, which is a melanoma breast surgery sort of specialty.
Okay.
And again, no reason to see a radiation oncologist if you don't need radiation, right? So it sort of depends. Generally, at a minimum, the gynecologic oncologist would have, a medical assistant, put you in the room, check your vital signs, make sure everything's going okay. A nurse or a nurse practitioner to sort of traffic some of the education and teaching, and to be available 24/7, even if the gynecologic oncologist is in the operating room or out of the country or on a plane. So that would be at a minimum. And if you're going to need chemotherapy, again, ideally the gynecologic oncologist would be that administrator of the chemotherapy, but maybe you need a medical oncologist. And again, every practice is a little different. I think that's okay. I think it's all about training, expertise, and volume.
So, what are some of the treatments? I know obviously everyone's different. We heard from some people who had surgery and didn't need any other treatment. We heard from some people who had both chemo and radiation, and a couple people who had internal radiation. Can you just explain in kind of very generalized terms what some of the treatments are?
So if it's a small cancer, just have a regular old hysterectomy. And it can even be done through the vagina or laparoscopically, and you go home the same day, and you're cured.
So I'm sorry, a hysterectomy?
So let me back up. So if you're done having your children, yes, have a hysterectomy. If you're not done having your children, then you can just have the cervix, part of the cervix removed. It's called a cone biopsy or a loop excision, and you're cured. So again, cancers caught early are almost 100% treatable. Now, if they're a little bigger, you got to have a hysterectomy and the lymph nodes biopsied. It's okay. And if it's too big to cut out, then you get chemotherapy and radiation. It's literally that simple.
We did talk to somebody who actually asked for a hysterectomy. She had had her children in her 20s. She was still in her 30s, but she said, I'm done having children. And it took her about 4 or 5 doctors before someone would actually do it for her. Can you explain that?
See, if it's a big cancer, it's really, really ill-advised to cut it out because you're going to need chemotherapy and radiation anyways. And all as the surgery does is put you at risk for a surgical complication and doesn't cause more cure. So this is the education. So you you talk to people. I understand why you want that cancer removed. I would want the same thing. But if it's not going to help you, then let's not remove it. Because if it's a big cancer and we remove it, you still need chemotherapy and radiation. And if you have a hole in your bladder or something goes wrong or a blood transfusion with your hysterectomy. So again, hysterectomy is important when early, but if it's not a small cancer, a hysterectomy is absolutely the wrong thing to do. And you have to explain. See what doctors do. Doctors are really good at explaining the what. This is what we're going to do, or I recommend. They need to explain the why.
So actually, it sounds like it's almost, for someone who's not trained in this, it almost sounds the opposite of what you'd expect. You'd expect if it's little, you don't need a hysterectomy. If it's big, you need to take the whole thing out. But what you're saying is it's exactly the opposite
Well, because when it's big and you do a hysterectomy, the hysterectomy is inadequate treatment.
because it's already gone other places.
Yes, and you need chemotherapy and radiation. Again, you have to explain the why, and you have to take time and ask questions to the patient. Tell me more why you think a hysterectomy would be good for you when I just told you why in my experience it's not. Tell me why. And listen and respond and be patient.
So can we ask about internal radiation, which a couple of the
Good
women.
question. Good question.
So tell us what that is and what the side effects are.
So when there's no uterus, because there was a hysterectomy done, there's no internal radiation. And essentially, when the cervix is intact, every single patient needs brachytherapy.
Brachytherapy is internal radiation. That's what it is.
The way radiation is delivered today, as opposed to the way it was 10 to 20 years ago, is much better. The side effects of radiation is much less. There still is some bladder irritation and some rectal irritation particularly. Again, it's better because we can more precisely deliver the radiation to the tumor and not the bladder or the rectum, but it is a risk. But that risk is, again, it's not great. I hate it, but it's better than dying.
Are there sexual side effects with some of the treatments that you're talking about, whether they're surgical or radiation?
Obviously, there are sexual changes when a woman goes into the menopause, whether it's a surgical menopause, the ovaries are removed, or whether it's a radiation menopause because the radiation causes the ovaries to stop functioning. So there are side effects of that. Now, when the internal radiation is given, it also affects the vagina. The vagina will heal, but because of the inflammation, it can stick together and close. And once the vagina is closed, it's closed. It's damaged. So we have to be vigilant, particularly when internal radiation is given, that we keep the vagina open. And maybe we can keep it open through sexual activity. The woman says, well, maybe, it's sore and raw, and so then you can use a dilator, and maybe you don't have a partner. But dilators have to be used correctly. They work. It's very difficult to prove that other than personal experience. But, any raw surface, even your fingers, if you were to sit here and take a piece of sandpaper and tape your fingers together for 3 weeks, they would grow together. Okay? And that's really what happens in the vagina. So you can lose the skin on your fingers, but if you keep them apart, the skin will heal, and it's the same in the vagina.
How do you address that with patients? I'm assuming, sex may be the last thing on their mind when they're going through chemo. What do you talk to them about?
Well, we try to treat the whole patient. We try to treat the patient emotionally and spiritually and physically. And physical is both, hormonal, sexual, cancer risk, and so on. So it's just part of the spiel. The good news is remember I said that, part of the team might include a nurse that has the opportunity to sort of educate. Yeah. Or a nurse practitioner, or the doctor can do it. One of the questions that I always get asked is what happens after the treatment. And there are sort of two things. One is survivorship. You have to survive the cancer, but you have to survive the experience. And whatever that looks and feels like for you, it's multidisciplinary. And there are individuals that specialize in survivorship. And really, as I always say, we're going to cure the cancer, but we're also going to keep you feeling good. Because if you cure the cancer and the patient's miserable, you haven't accomplished anything. Second is how to watch to see if the cancer comes back, because cancers that are small when they recur are easier to treat. So we generally do a PET CT 3 to 6 months after, just in case that it popped up somewhere. And then frequently we would continue those imaging, although they may not pay for the imaging, depending on the scenario. But if you give radiation, for example, to the pelvic area and chemotherapy because it was too big to cut out, you would do that post-treatment surveillance, 3 to 6 week scan, again, know how to interpret it. And some of those patients can still be cured. It's really important. The other thing is, in addition to the systemic failure risk, you want to look in the vagina. And so you can continue physical examinations at 3 to 6 month intervals, and sometimes even with an HPV or Pap test. And then really innovative is we can actually test in your blood the cancer DNA. So we used to say, oh, we're going to look for cells in the blood. Actually, we can look for DNA in the blood. And it's very innovative. And I'll hopefully be able to show you data within the next 6 months how that's really exciting.
What's something you wish all of your patients knew about cervical cancer before they came to you?
If I was to have one wish as a gynecologic oncologist, I would like every woman to know that cervical cancer is preventable. You can get vaccinated against it. You say, well, the vaccine came out in 2006. It's only approved up to the age of 26 and effective up to 45. Well, then you can test for the virus that causes it. So if we learned anything from COVID, if you want to know if you have it, do a viral test, you can do that. And if you want to prevent the COVID, you can get a COVID vaccine. I wish every woman would know that. And that would put me out of business so that I could concentrate on ovarian and endometrial cancer where there is no prevention.
Let me ask one more question. You'll have a similar answer, I'm sure, but I just want to specifically ask what you would say to a parent who was considering the HPV vaccine for their teenager or a young adult.
So I ran into one of my OBGYN friends the other day, and he says, Brad, I made a serious mistake. I'm like, what'd you do? He says, when my daughter was young, I said, I'm going to let her get older so she can make her own decision on the HPV vaccination. I could have had her get it when she was young. Now she's older and she doesn't want it. If my daughter gets cervical cancer and can't have a child because she needs a hysterectomy, I will never forgive myself, because I made a bad decision by not insisting that she get vaccinated. I will never forgive myself. So I think we have to be parents. And by being parents, we have to coach our children to do the right thing. And there's no question that the right thing in this 11, 12, 13 age group is to get HPV immunization, which not only prevents cervical cancer, but vaginal, vulvar, anal, and head and neck cancer.
Thank you so much. I just want to thank you for taking the time to be with us and for sharing your expertise with us. You obviously are very well versed in this, and people need to learn a lot about cervical cancer in Cervical Health Awareness Month.
And thank you for all you're doing. Keep up the good work. Good seeing you today. Thank you.
Thank you.
All right, bye.
Thank you so much for listening. If you want to listen to all episodes in our Cervical Cancer Survivor Series, head to nccc-online.org, where you can also find a lot of information about cervical cancer prevention and screening.